All right, everyone, buckle up for this deep dive. We're tackling a case that'll really put your diagnostic skills to the test. A medical mystery that even stumped some seasoned clinicians. We've got a 44-year-old male patient presenting with a whole mix of symptoms, lab results, imaging findings, you name it. This one, it really highlights how important it is to be super thorough with your differential diagnosis, thinking outside the box, and also the value of having that experienced attending guiding you along the way.
Yeah, absolutely. What makes this case so interesting is how the patient initially presented. It was this blend of common and then unusual findings that could easily lead you down the wrong path if you're not careful.
So let's start with what we knew right off the bat. Our patient, he was reporting fatigue, weight loss, chronic pain, like in his hip and his chest wall. Sounds pretty routine, right?
Yeah.
But then he goes and fractures his clavicle just from pushing himself up from a chair.
Wow.
And then turns out there's this lytic lesion right there at the fracture site. That's a big red flag, right?
Oh, yeah, definitely. And then when you factor in his past medical history, it just adds, another layer of complexity to it all.
Right.
He's got a history of kidney stones, chronic kidney disease, hypertension, and get this, three previous myocardial infarctions.
That's three.
Three. And to top it all off, there's a family history of renal cell carcinoma.
So already a pretty complex patient, to say the least.
Yeah.
And then the lab results come back, and those just amplify the puzzle even more. Hypercalcemia, super high parathyroid hormone levels, like way up there.
Yeah.
Elevated alkaline phosphatase, low phosphorus, and even leukocytosis.
Yeah, there's a lot to unpack there.
Yeah, a lot going on.
So, the resident, looking at all this, they considered primary hyperparathyroidism, parathyroid carcinoma, humoral hypercalcemia of malignancy, all, valid considerations given the evidence.
Makes sense. Let's break down the reasoning behind each of those a little bit. So primary hyperparathyroidism, that was a strong contender, right? You got the elevated PTH and calcium, history of kidney stones, that high alkaline phosphatase.
Yeah, all pointing in that direction. But, while the resident's differential was, it was good, the severity of that hypercalcemia was, I made sure to emphasize that point.
Right.
This wasn't something you could just, sit back and monitor. Managing that hypercalcemia crisis right away, that was absolutely critical, especially given his kidney disease already.
Absolutely. That's something that could easily be missed when you're so focused on the diagnosis, right?
Exactly. And so to get a clearer picture of what we were dealing with, I suggested some additional tests. Ruling out familial hypercalcemia, getting some more detailed parathyroid imaging, screening for MN syndromes, all crucial steps.
Right, because with a presentation this complex, you got to think about the possibility of like a double pathology, right? Like more than one condition contributing to the whole picture.
Absolutely. Couldn't rule that out. And then, to make things even more complicated, the initial imaging results, they added another twist to it all. The chest x-ray, the CT scans, even the PE scan showed multiple lytic lesions, which really raised the suspicion for metastatic cancer.
So things were swinging towards malignancy at this point.
Yeah.
But then, to add to the confusion, that initial sestamibi scan came back negative, which cast some doubt on the primary hyperparathyroidism diagnosis.
Yeah, that negative sestamibi was a really important piece of the puzzle. However, the biopsy of that clavicle lesion, it revealed a brown tumor.
And here's where it gets really interesting, right? Because brown tumors, those are consistent with like really bad hyperparathyroidism, but not necessarily cancer.
Right.
So were we back to square one then?
Not quite. We had to refine the differential again.
Okay.
We had to consider the possibility of ectopic PTH secretion, meaning that the PTH was coming from, a non-parathyroid malignancy. We also had to consider that maybe there was some interference with the PTH assay, which might explain those super high PTH levels despite the negative sestamibi.
So the mystery deepens.
Yeah.
And we've got this mediastinal mass that needs further investigation. Could it be a PTH secreting thymic carcinoma, parathyroid carcinoma metastasis, lymphoma? I mean, there are so many possibilities.
So many possibilities, and that's exactly where we'll pick up in part 2. We had to come up with a new plan to figure this whole thing out.
So we left off with quite the diagnostic puzzle, right? We've got this mediastinal mass, weird lab results, and that negative sestamibi scan.
Mm-hmm.
So what happened next? Where did you go from there?
Well, the plan was to The revised plan, I should say, focused on two main things. We needed to repeat that sestamibi scan, make sure to include the chest this time.
Okay.
And then we needed to get a biopsy of that mediastinal mass.
Makes sense. See if that mass was the source of all that extra PTH. And of course, the biopsy gives you that definitive tissue diagnosis.
Right, exactly. And the results, those were pretty telling. The repeat sestamibi scan, it lit up in the mediastinal mass right where we suspected. And then during the surgery to remove it, the patient's PTH levels, they just plummeted back down to normal.
Wow.
So it was pretty clear we had found the culprit, ectopic parathyroid adenoma hiding out there in the mediastinum.
So after all that, it seemed like a pretty straightforward case of an ectopic adenoma.
Yeah.
Case closed.
Not quite. Not so fast. We had one more twist coming.
Oh, no.
After the surgery, the patient developed really, really bad hypocalcemia, like profound hypocalcemia.
Oh.
And that's a classic presentation of hungry bone syndrome.
Hungry bone syndrome.
Yeah, it happens, sometimes after you take out a parathyroid in patients who have had really severe hyperparathyroidism for a while, especially if they've got significant bone disease. Basically, the bones have been starved of calcium for so long, so once that PTH drops, they start gobbling it up like crazy.
Oh, hungry bone syndrome. It's a reminder that even when you think you've solved the case, things can still get complicated.
Yeah, exactly. But, the real shocker came from the pathology report of that supposedly straightforward adenoma.
Okay, yeah, let's dig into that pathology report because I have a feeling this is where things take another unexpected turn. So what did it say?
Okay, so the report, it described this parathyroid tumor. It was encapsulated, measured about 2.5 centimeters at its biggest point, pretty hypercellular too.
Sounds pretty typical so far.
Yeah, so far so good. But then there were some concerning features. There was cellular atypia, and they found multiple nests of these tiny tumors within the fibrous capsule itself. And then to top it off, there was this separate nodule, well-defined, about 0.5 centimeter, found in the adipose tissue right next to it.
Whoa, hold on. Atypia, nests of tumors, and extranodule. Those are red flags for something more serious than just a benign adenoma, right?
I got it. The resident, they did a great job picking up on those details. And, to add even more suspicion, the immunohistochemical staining of that extra nodule, it came back positive for PTH, cytokeratin, and chromogranin.
Okay.
And it had a Chi-67 proliferation index of 7%.
Okay, so let's break that down a little bit. First, the immunohistochemistry. What made those results so important?
Well, the PTH positivity, that told us that the nodule was definitely parathyroid tissue, ruled out any other kind of unrelated growth.
Cool.
But the cytokeratin and chromogranin, those being positive, that's not as common in benign parathyroid adenomas.
Right.
And they can sometimes be associated with, more aggressive behavior.
Okay. And what about that Chi-67 index of 7%? What does that tell us?
So the Chi-67 index, that basically measures how quickly the cells are dividing.
Okay.
And a higher index means faster growth, which could be a sign of, aggressive behavior.
Yeah.
In parathyroid tumors, specifically, a Chi-67 index over 5%, that starts to raise concerns for malignancy.
Right.
So that's 7% in this case. It just added to our suspicion.
Yeah, definitely. So basically, the pathology report was showing us something a lot more complicated than just a simple benign adenoma, right? It was something potentially more serious.
Exactly. So we had to revise the diagnosis again. It wasn't just an ectopic adenoma anymore. It was reclassified as at least an atypical parathyroid adenoma with low-grade parathyroid carcinoma as a real possibility.
Okay, so now I've got this new potential diagnosis, atypical adenoma or even low-grade carcinoma. So what does that mean for how we manage this patient?
Well, both of those, they carry a higher risk of recurrence and metastasis compared to those typical benign adenomas. So, long-term follow-up, being really vigilant, that was absolutely crucial now.
Makes sense. So what specific steps did you recommend for monitoring him?
Well, we had to be more proactive with this, right? So we recommended checking his calcium, PTH, and alkaline phosphatase levels every year. And we even talked about, maybe doing it every 6 months for the first couple of years after the surgery, just to catch any recurrence really early.
Okay, so more frequent blood tests, stay ahead of any potential problems. What about imaging? Did you recommend anything specific there?
Yeah, imaging was crucial too. We recommended yearly neck ultrasounds and chest CT scans, and we said to do that for at least 5 to 10 years.
Wow.
That way, we could keep an eye out for any local recurrence, any distant metastases, lungs and bones. Those are common spots for parathyroid carcinoma to spread. And we also talked about using FDG PT-CT if we had any clinical suspicion of recurrence down the line.
So a much more intensive monitoring plan than you'd typically do for just a benign adenoma.
Yeah.
What else did you do?
Well, we really emphasized the importance of evaluating for Menin syndromes, especially MEN1,
Right.
given his history of those multiple heart attacks and the family history of renal cell carcinoma.
Right, right.
We strongly recommended doing genetic testing for the MEN1 mutation. Sometimes those parathyroid tumors that are linked to MEN1, they can look atypical and they can even be clear carcinoma.
It sounds like you were really covering all your bases.
Trying to.
So with all this new information, how did you go about explaining the revised diagnosis and management plan to the patient?
Well, we had to be really transparent and clear with him, explaining that the pathology report raised some red flags and that we needed to be extra careful about monitoring him. We went over that enhanced follow-up plan and why we were recommending the genetic testing. We also made sure to address any anxieties he had and reassured him that we were going to be proactive with his care.
That must have been a lot for him to take in. It sounds like you were very thorough in making sure he understood everything.
We tried our best, Transparency and open communication, that's essential when you're dealing with a potential cancer diagnosis.
Absolutely. And did that expert pathology review confirm what you were thinking? Was it an atypical adenoma or was it something more?
Well, that's where we'll pick up in part 3. We'll reveal the final diagnosis and what it meant for this patient long term.
Okay, so we're back. And I'm sure everyone's on the edge of their seats waiting to hear what that expert pathology review had to say. Did it confirm those suspicions of atypical adenoma or even carcinoma?
Well, yeah, after the expert review and using the World Health Organization's 2022 criteria for these parathyroid tumors, we ended up revising the diagnosis to parathyroid carcinoma.
Carcinoma, wow. So it was malignant all along. What were the specific things in the report that really solidify that diagnosis?
So the biggest thing was that there was capsular invasion, those nests of little tumors within the fibrous capsule, and then that separate nodule in the adipose tissue, that all showed that the tumor had broken out of its boundaries.
Right.
So that, close with that Chi-67 index of 7%, that really pointed to a minimally invasive malignancy.
Okay, so even though you successfully removed the tumor, the fact that it had spread outside the capsule, that meant it was a carcinoma. Mm-hmm. How did that change how you were going to manage this patient?
Well, once we knew it was carcinoma, the focus shifted right away to staging the tumor.
Okay.
We had to figure out how far it had spread and what the risk of metastasis was.
Right.
And then we also had to think about adjuvant therapy.
Okay, so let's talk about staging first. What staging system did you use and what did you find?
We used the TNM system, which looks at the size and spread of the primary tumor, T, whether it's in the lymph nodes, N, and if there are any distant metastases.
Oh.
Thankfully, all the tests for lymph node involvement and distant metastases came back negative. So we classified it as PT1, N0, M0, meaning it was relatively early stage.
Okay, early stage, that's good news. But we are still talking about cancer here. Did you recommend any adjuvant therapy?
Well, adjuvant therapy for parathyroid carcinoma, it's tricky. There's no real proof that radiotherapy helps after you completely remove an early stage tumor, especially if it's smaller than 4 centimeters.
Okay.
But given the atypical features in this case and that microscopic evidence of capsular invasion, we decided to present the case to the tumor board.
Okay.
Just to discuss whether or not external beam radiation therapy might be a good option.
So you considered radiation, but you didn't definitively recommend it. What were the factors that influenced that final decision?
It was a tough call, We had to weigh the potential benefits of radiation against the potential risks and side effects. And in this specific case, we decided it was better to really focus on close surveillance, look for any signs of recurrence, rather than jump into adjuvant therapy right away.
That makes sense.
Yeah.
Catching any recurrence early is key. What did that long-term surveillance plan look like?
So we set up a really strict monitoring schedule. We started by checking his calcium and PTH levels every 3 months for the first 2 years. Most parathyroid carcinomas, they come back within the first 3 years after surgery, so finding any recurrence early is crucial.
Yeah.
And we said if his PTH levels start to go up, then we'd use imaging studies like FDG-PE or specialized octreotide scans. Those can, target the somatostatin receptors that are often found in parathyroid carcinomas.
Right.
And that would help us pinpoint exactly where any recurrence might be.
So frequent blood tests, targeted imaging, really staying on top of things. How did you manage his hypocalcemia over the long term?
Yeah, that was an ongoing process. At first, we had to give him intravenous calcium and high doses of calcitriol. But as his calcium levels got more stable, we switched him over to oral calcium carbonate and calcitriol. We had to, constantly adjust the doses to make sure he wasn't getting hypercalciuria, especially with his history of chronic kidney disease. And of course, we were monitoring his magnesium and phosphate levels very carefully too.
It sounds like even after the surgery, there are a lot of things to keep track of. Looking back now, is there anything you would have done differently in this case?
Well, it's always good to think back and analyze how we made decisions. In hindsight, if we had gotten a preoperative 4D CT scan of his neck and chest, that might have helped us diagnose and find that ectopic adenoma faster.
Yeah, hindsight's 20/20, right? So let's fast forward to that 5-year follow-up. What happened?
Unfortunately, at the 5-year mark, his PTH levels started to climb again. They got up to 368 pgml, and his calcium was a little high too at 10.2 milligl. We did a sesame B-spec fusion scan, and it showed this new lesion in the mediastinum, about 1.3 centimeters, which made us think the carcinoma had come back.
Oh, that's not good. What about those bone lesions that were found earlier? Were those still stable?
Yeah, the bone lesions, those stayed stable. Thankfully, no new fractures. And we even saw some improvement in his bone mineral density, in his radius and lumbar spine. But his femoral neck bone density actually decreased. So, it just goes to show how complex and unpredictable the effects of hyperparathyroidism on the bones can be.
Yeah, some good news, some bad news. So recurrence obviously is a big concern, but at least the bone lesions weren't getting worse, and there was some improvement in bone density. So what were the next steps?
Well, given the findings, we sent him back to thoracic surgery for more evaluation and imaging of that new mediastinal lesion. And this is the tough part. Even though we tried to stay in touch with him, he ended up being lost to follow-up.
Lost to follow-up. That's always hard to hear, especially with a case this complex.
It is concerning. But, all we can do is hope that he found care somewhere else.
This case has been a wild ride, that's for sure. So many twists and turns. What are the big takeaways for our listeners, especially for those residents and fellows out there who are dealing with these complicated endocrine cases?
I think this case really drives home how important it is to be thorough and flexible with your differential diagnosis.
Right.
You have to always be reassessing as you get new information, and you have to be super vigilant and watching out for complications and recurrence, especially when there's a chance of malignancy.
Absolutely. This case is a perfect example of why we as clinicians need to stay curious, keep challenging what we think we know, and never stop learning. To our listeners, what did you learn from this deep dive? Share your thoughts with us using the episode hashtag, and we'll be back soon with another fascinating case. Until then, keep those brains sharp.